Okay.
We are clinical group D, and this is our concept map.
And this is our patient. We have got approval to show this picture. So he is a 37-year-old male. He's a full code, no known drug allergies. He is 92 kilograms. So he came in today because he was thrown from an electrical pole, suffering a head injury. He has 3rd and 2nd degree electrical burns. He is intubated and sedated in the ICU, has an EVD placed to monitor ICP, and has undergone fasciotomy and debridement of necrotic tissue. So we have set some priority problems. The first one being 2nd and 3rd degree electrical burns. Second one being head injury with increased ICP. Third one is urine output of 200 milliliters in 24 hours. And fourth one is he is married with 3 children, so his psychosocial.
The initial priority problem that we came up with for this patient is a head injury with increased ICP. The nursing diagnosis that goes along with this is altered cerebral perfusion related to increased ICP, resulting from a traumatic brain injury as evidenced by initial EVD reading of 20 millimeters per mercury. This is backed up by this assessment data, initial heart rate of 90, a temperature of 97, and an OT of 96% on a ventilator. The initial ICP is 18, which we all know is high, a Glasgow Coma scale of 12 during his sedation vacation, which is low. Pupillary responses during sedation vacation were reactive. The initial blood pressure is 90/60, and the ventilator settings are here. A PEEP of 15, a tidal volume of 6 to 8 milliliters, and 12 breaths per minute. Because of this assessment data and this nursing diagnosis, the SMART goal we came up with was cerebral perfusion adequate to meet tissue needs by end of shift. As evidenced by these goal indicators that we came up with, we would love to maintain a CPP between 60 and 100, maintain a MAP of 70 to 105, and a decreased ICP from 18 to normal, which is 5 to 15. And when we see these, then we can know that the ICP is improving. The nursing interventions we came up with to try to achieve the SMART goal was maintain lowered ICP. We know to do that by elevating the head of bed, decrease external stimuli, avoid things like cluster care. We want to give IV mannitol, which is a osmotic diuretic that's going to help get rid of any extra fluid that might contribute to the increased ICP. We want to decrease agitation by administering lorazepam, PRN if we notice any agitation from the patient, and then some education here in regards to the EVD and just having the patient avoid certain movements. We can delegate these to this here. We have like labs that can be done. The UAP can do vitals assessments and keep the nurse updated on those. The surgeon is going to place the EVD, and the RN, all these nursing interventions are within their scope of practice. We can tell this evaluation or these interventions are met by an ICP reading of 15 after giving mannitol. The BP would be rising also as well after the mannitol, as well as the MAP and the CPP.
Okay, I'm going to be talking about the connections that are made here. The first one will be the ventilator settings, which will be set to keep adequate perfusion of the brain. And whenever there's adequate perfusion, there will not be hypercapnia, which would increase ICP. So this connects to our decreasing ICP. Additionally to that, we'll be giving mannitol. And so mannitol will decrease ICP, but it will also connect to the increased urine output down here, which our priority problem down here is the urine output, so mannitol is going to help here. With the urine output being so low initially, there will be neurochecks performed, a Glasgow Coma scale. In order to keep up to date with the ICP up here, we will also be performing the Glasgow Coma scale for the patient. So we can see the connections of the head injury with increased ICP and the urine output and be able to draw connections. Do I point to it?
Mm-hmm.
Okay. So our second priority problem is the second and third degree electrical burns. He is at a risk for fluid volume deficit related to the burns, which is evidenced by the rule of nines. He does have the left arm, the torso, and left leg burned, so it's 45% of his body. And then our assessment is initial BP is 90/60. His ABGs, pH is 7.34, carbon dioxide is 24, and his bicarb is 20. He does have some EKG changes, and his burn point entry was the left hand, and the exit point was the left leg, because he did get it while working. He does have some edema, and his heart sounds, S1 and S2 are present but faint, and his lung sounds are shallow. So our goal is that his blood pressure will return to the normal value of 120/80 by day 3, and so with like normal EKG readings and equal intake and output levels, and we're gonna give him mannitol. So we're gonna have 2 large bore IVs, so that we can administer fluids and medicine. We're gonna have a urinary catheter, so that we can monitor output, and we're gonna take vital signs. We're gonna elevate his extremities that have edema. There's gonna be a whole team of people taking care of him, so his physical needs and like his mental and emotional needs as well. And then the evaluation, his goal is going to be met, so the blood pressure is going to return to 120/80 and was maintained through discharge. And then he's going to have help for the next 6 months with the coping part of the burn.
Okay, so some of the priority connections that we made for this problem of the burns is going to be our fluid resuscitation and how that's going to be affected by the other priority problems. So it's important that we do give fluids, but it's also very important that we have in mind that we have increased ICP here. So it's important that our nurses are making sure that they're watching for any fluid overload also. It's also tying into our other priority problem down here of the urine output. We are giving fluids, but like I said, because of the other issues that we have going on, we need to make sure that we are monitoring closely, which is why there's connections between having a Foley catheter, monitoring strict I's and O's, and making sure that we are watching for signs and symptoms of altered ICP levels. Our second connection is going to be with the burns, also connecting to our psychosocial aspect down here. We put that it's important that they are with case management and social workers to be able to get resources that they need, either financially or any other problems that they have. Burns can be affected by the family. Okay, so there are many different psychosocial aspects that go along with burns also. We made a lot of the connections here. Because he does have a family, having children, it can be kind of hard on the children seeing their father with burns. Also, he's going to be undergoing a lot of long-term treatment with PT and OT, and it's also important that he is assessed with his psychosocial implications often. So we have that connected here.
Okay, so now we are going to talk about priority problem number 3, which is the urine output of 200 milliliters in 24 hours. So this is evidenced by the urinary output being low, which we had already talked about, weight gain of 2 pounds, and then he has several labs that are out of range here. And our goal is to improve urinary elimination within 48 hours. And to meet that goal, we're going to look for an increase of urinary output to 400 milliliters in 24 hours. The weight will be back to his baseline of 205 pounds, and his labs will be within range. Some interventions we're going to do to support this is we're going to implement seizure precautions, and also neurochecks Q2 due to his sodium level being low. And then we're going to place a urinary catheter and monitor his eyes and nose Q2. And we're going to delegate those as needed. We have listed here the different roles. And then to evaluate, we are going to just look at his output and see if it meets our goal of 400.
Okay, so for our connections, we started on here with sodium level is low and can cause seizure precautions. So since it's low, we're going to do seizure precautions. We have, for the ICP, they're given mannitol, which is the osmotic diuretic, so it will increase the urine output. So we connected to goal indicator, patient's output increases 400 milliliters in 24 hours. And then whenever they also give mannitol, the weight will decrease due to the diuretic pulling off the fluids. So again, our goal indicator is patient weight is back to the baseline. And then we also connected the urinary catheter over to whenever the intervention for their burns is inserted indwelling urinary catheter. So we just said urinary catheter to monitor the urine output.
So in our priority problem number 4 is our psychosocial, and our patient is married with 3 children, which poses a big problem because now, since he is unable to work, it puts them in a financial instability as he's not having a constant income. So when we were looking at this, we had the assessments that the wife is a stay-at-home mom who occasionally works as a substitute teacher, so her income is very fluctuational. The kids are going to understand somewhat of what's going on with dad, and they're asking if he's going to be okay, so there's going to be some trauma of what's happening with this situation. His mother lives with them, so that's an added burden other than just having to worry about providing for the kids. They have to provide for his mother and the care that she needs. The wife is now very angry as she goes to church and is asking why this is happening to her husband, and so we want to get her to speak with like a chaplain or a therapist to try and solve that problem. So we think that she and her family will be applicable for some workers' comp or disability while he is not able to work, as this did happen on the job. So we think that she should apply when she gets the information about workers' comp and unemployment, so they can have some sort of income to be able to provide for their family. So as the nurse, we'll give her information about what to do, places for rehab, places for like therapy for the children when they see this traumatic thing happen to their father, and we need to get her more steady in thinking that just because this happened, it's not the end of what's happening in her life. She can provide while he's unable to, and help him be able to get the care that he needs. And we delegated to a case manager to help them get set up with facilities to help his care after he gets out of the hospital, a social worker to get them the things that they need, a chaplain to just kind of ease what's going on in their minds, and then therapist for the children and even the grandmother or the wife. And we see that this can be done as a nurse, and with all the help from all the delegation, we can see that it makes a difference in the patient's outcome and the family dynamic.
Okay, so now we're going to do the connections for the psychosocial aspects. So as Lindsay talked about earlier, a lot of the psychosocial things that we're going to be watching for related to our other priorities is the family's reaction and kind of just the surprise that it can be to see your loved one in an ICU setting and in that state. So as far as burns and increased ICP go, it's going to be a lot of outward appearance changes that we're going to see. So as far as the ICP, the patient is sedated and he's on a ventilator right now, and so that's a lot of machinery and a lot of things that the kids and the wife might not understand. beforehand. So we want to educate them well, let them know what the machines are doing. They're helping him breathe. He's not waking up because we have given him some medication, things like that. And then the burns, like Lindsay said, that can be really hard on the patient's body image, but also on the family member seeing him with the burn. So just letting the family know beforehand what to expect is going to be important for their social health. And then with the burns, it can cause permanent debilitation, and so that can increase his risk of not being able to work later on. And as we discussed previously, he is the provider for the family primarily, so looking into the things like the disability insurance can help with getting him some kind of income. But those are just some of the connections that we see that affects the family's psychosocial health.
Our other two evidence-based practice, one was how to dose for mannitol specifically for increased intracranial pressure. And so we got our information here, the 1.25 grams per kilogram. So we were able to implement evidence-based practice here, which affects this priority of the head injury, this priority of the urine output. The second resource is respiratory management in patients with severe brain injury. So this evidence-based practice helped us to set the ventilator settings for adequate perfusion of the brain, while also helping the patient to recover more quickly.
Okay, so we have two evidence-based practice articles here that we used. This first one has to do with our priority problem of the 3rd-degree burn, and it really has to do with our interventions and dealing with eyes and nose. Our second one that we have is actually our textbook, and that has to do a lot with our interventions, but also encapsulates a lot of the other aspects of our concept map here.
Okay, a psychosocial resource that we used is the Oklahoma Workers' Compensation Committee. They have a lot of information about how to apply for workers' comp, as well as what your eligibility is based on if you are permanently disabled or temporarily disabled, and then also if it's partial disability or total disability, which is how we came to the conclusion that our patient probably would best be supported by permanent total disability.